Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am back. We had a program this morning. We are back this afternoon. We're going to be talking about circulation matters, identifying and treating peripheral arterial disease, or otherwise known as PAD. I have Dr. Cody Kraemer here with me. He is a TMCOne vascular surgeon. Welcome, Dr. Kraemer. How are you today?
Doing good. Thank you so much.
Good. So you have an online audience watching as well as, an in-person audience. So if you're watching from home, please feel free to put any questions into the chat and we'll be sure to ask Dr. Kraemer afterwards. Dr. Kraemer, I'm going to go ahead and put your PowerPoint up for you so that you can get started.
All right. Thank you, everybody. Appreciate you coming. I'm sorry I was running a little bit late. I was actually up all night long. And so if my mind goes blank for a second, just bear with me. So we're going to talk about peripheral arterial disease. This is something that I face every day. This is what I faced all night long last night. And I find it to be a very important thing, and I have a passion for it because it has significant impact on patients' lives. And so let's just jump right in. So peripheral artery disease. So we're going to talk about kind of what it is, what are common signs and symptoms. We're going to identify what are potential risk factors. And then we're going to talk about the treatments, both medical therapy and surgical therapy. So peripheral artery disease, essentially it's a circulatory condition in which the blood vessels, the arteries, which are the vessels that take blood outside of the heart to the rest of the body, are narrowed and reduced. And this is most particularly seen within the limbs, so upper and lower extremity, with the lower extremities being most affected. This affects about 10 to 12 million people in the United States every year. And signs and symptoms. What I talk about with peripheral artery disease, it's a spectrum disease. There's a lot of diseases like, yes, you have it, no, you don't have it, or yes, you have it, and you may have this complication of it or that complication. Really, this is slow progression of plaque that builds up over time. And so early on, patients may develop plaque buildup, but they may have absolutely no symptoms. But we're seeing signs that the disease processes, and we'll talk about those here in a minute, that lead to the plaque buildup is starting to deposit this plaque over and over. And as it narrows the vessels more and more, then we start to see restriction of blood flow to the organs that are affected. And then that then causes an effect, okay? So the first thing people notice, like I said before, the most common location is in people's legs. So we're going to really kind of focus on lower extremity or leg peripheral arterial disease, is as somebody goes for a walk, they may go half mile or a mile, and they may notice like their calves cramp up or their calves kind of get weak. And it's usually in the calf muscles because that's the furthest big muscle group that's away from your heart. So usually it's like multiple blockages going down, whether it's a full blockage or just partial narrowing. And when your muscles are saying, give me more and more oxygen, if you cannot meet the demand of the muscle, then that's when you'll get the response. And usually, like I said, most people call it as like a cramping kind of a pain. Usually then at that point, you have to stop, let your body catch up again, rest, the pain subsides, and the individual can go about that same distance or so again before they sort of get the pain again. And it's pretty reproducible. So if somebody comes into my office and they say, hey, doc, I got sent over by my primary care doctor. They're concerned about these leg pains that I'm having. And you talk about, at night I sometimes get cramps. And then sometimes when I first start walking, sometimes when I'm walking, it gets better. Those are a little bit more inconsistent. This should be something that as the muscle is needing more and more oxygen, it's working more and more, that's when the patient will experience the symptoms. Because there's a lot of things that can mimic it, okay? And so as the plaques get worse and worse, that distance then gets shorter and shorter. And depending on how severe that is, then you kind of talk about different treatment options, and we'll get into that here in a minute. Now, if it gets to the point where you're hardly getting all the blood or the amount of blood flow to almost maintain tissue, which then your toes and your heel are kind of the furthest tissues away from your body, then people will develop what we call rest pain, which is typically classified as like you're laying in bed and people get a burning pain, usually in their toes or their heel, or just a vice kind of grip pain. And some people will even have to sleep with their leg down, and just that little bit of extra gravity pulling the blood flow down will make a significant difference. When you start to move into the rest pain and gangrene, where the tissue is actually starting to die because you have such poor blood flow, we call that chronic limb-threatening ischemia, or kind of an older term people still use is critical limb ischemia. This is where you're actually getting, at risk of not just losing part of your toes, but even your whole foot. And it becomes a very serious condition in which, we really need to do something sooner than later. So the way we kind of do the diagnosis for peripheral artery disease is a lot of it is listening to the patient. The patient's going to give you the clues and hints. Just kind of like I described earlier, I'll get a lot of people sent to me for different types of leg pains, and it's kind of having to differentiate, okay, is this a nerve-related pain? Is this just a muscle or a joint kind of issue? And so listening to the patient's story and how they're describing the pain puts a lot of emphasis on what do we think is actually going on. Now, not everybody has the same, what we say, like textbook presentations. So we're humans, we're complicated beings, and we have a lot of different things going on in our bodies all at the same time. And so sometimes it is a little bit of artwork or saying, hey, this may be this or it may be that. And we're going to do some testing to kind of help differentiate. And a lot of people have more than one thing going on at the same time as well. So like we talked about earlier, the arterial claudication, that reproducible pain in the calf or thighs with exertion, and it's relieved by rest. That rest pain, where we talk about pain in the toes or the heel, that's more of a constant thing, worse usually when people are sleeping because they're typically have their legs up. Smoking is a huge risk factor. So someone with a long-term smoking history, your thought is, well, maybe this is more of a blood vessel related and arterial issue. Other risk factors, age. As we age, this is typically a disease process of older individuals. It's really rare to see somebody in their 30s, 40s, even 50s kind of dealing with this. Other things like high blood pressure, high cholesterol, diabetes, chronic kidney disease, all those things contribute to these plaque building up over time. Then, another important thing that can give you clues and indicators is a good physical exam. So do patients have a good, strong pulse in their foot? If you got a good, strong pulse in your foot, it's probably something else that's causing it. When you get restriction of blood flow and you lose that pressure, it becomes very difficult to feel the pulses. Doesn't mean you're not getting any blood flow down there, but it's just not a normal amount. And then doing different diagnostic testing, which is probably the next most appropriate step if there's high suspicion that you may or may not have PAD. So one of the very first kind of almost like a screening test, and it's a non-invasive exam and very simple to do, is just a simple comparison of the blood pressure in your arms to the blood pressure in your legs. And so if they're about equal, then you're saying, okay, you probably don't have peripheral artery disease. You're getting normal pressure and flow down to the foot. And as you see in that chart, you get different severities of PAD. And we'll put people in like a mild category, a moderate, or severe, just based on the pressure alone. Now, this doesn't always correlate with patient symptoms. I get some people that have very little symptoms, but they may be in the severe category. And I get some people that are in like the moderate category that have very significant symptoms. And so some of that is also how it's routed and what tissues are affected, and depending on the exact flow patterns. where this is just measuring, hey, what's the highest blood pressure flowing vessel down to the foot? Next is if you have an abnormal arterial duplex, or excuse me, an abnormal ABI, then the next thing your doctor may or may not order is a type of ultrasound we call an arterial duplex. And this is really looking at the flow through the blood vessels. And it gives us more of an anatomical, hey, here are the locations where we're starting to see the blockages. And typically speaking, this is less of a screening exam. It's more of a, okay, yes, you have peripheral arterial disease, and we're starting to move into the point where we're kind of considering, should we or should we not do a procedure? Or if you have had a procedure, to kind of monitor the long-term outcomes of that procedure, because sometimes you may or may not need a re-intervention depending on what's going on. And so the duplex, essentially the way it works is you can see on the waveforms there that shows, is that a normal waveform? But really the way we measure blockages on a duplex is by speed. So the peak and the upward stroke you see on the waveform, that gives us a clue to how much narrowing may or may not be there. And if you imagine a garden hose, it has a fluid of water coming out at a constant rate. You stick your thumb over it, it sprays faster. And the faster it sprays, the more of a blockage that you're occurring. And it's kind of a similar concept to that as far as how we measure it. There's some things that go into that. You know, if you have a really fast flowing vessel to begin with, for whatever reason, then just because it meets a certain number doesn't necessarily mean it's a blockage. So you kind of compare it to the vessel before to the vessel where you're at. And so there's ratios and other things that go along with that. But really all that we're looking for is, where is the anatomical blockages that may be contributing to the symptoms that you're experiencing? So like it helps guide physicians, vascular surgeons, an idea of, okay, because you have a blockage in this blood vessel, I would recommend that we do this treatment or that treatment, okay? Other things like CAT scans and MRIs, those are other ways to get some of the anatomy. Now, the kind of first line therapy for all these things is medical therapy. And what is quote unquote medical therapy? Well, it's really treating all the medical conditions that cause the plaque to happen. So a lot of these are like risk factor modifications. So smoking is definitely by far the biggest contributor to peripheral arterial disease. So you're more likely to develop symptomatic peripheral arterial disease rather than symptomatic coronary artery disease, or things like angina, chest pain, related to blockages in the blood vessels of the heart. You're also 2 to 6 times more likely to develop peripheral arterial disease than anybody who doesn't smoke. So really significantly increases the chances that an individual gets it. There's also higher rates of that more severe advanced forms, that critical limb ischemia that we talked about. And if you have more of those advanced forms, then there's a higher chance that you develop amputations. Or if we do an intervention on you, the long-term results of those interventions become shorter and shorter. Really, this all comes down to say is, every time I see a patient and if they're smoking, it's the biggest thing I try to encourage them. I always say, you know, it's so much easier said than done. Very, very difficult to quit smoking. And those that have quit smoking, I always congratulate them on that, because it's a huge thing for their overall health. It's a big thing to overcome those things. So even if it was 30 years ago, I always say, awesome for you, good job. And make sure to say, don't pick it up again. So there's different medications, and usually I defer this kind of stuff to the primary care doctor, because they're more up to speed on interactions with other medications the patients are taking, but lots of different smoking cessation programs, counseling. Seen a lot of people just say, oh, I just quit cold turkey one day, done. You know, for a lot of people, it's, I had a major heart attack and I had to make a choice right here and now. And so it's different for every person, but this is kind of one of the big things I talk about in the clinic. Other things, medications to kind of go along with treating PAD, antiplatelets, things like aspirin or Plavix. It's American Health Association Class 1 recommendation. So there's a lot of things coming out in the news in the last few years. Oh, a baby aspirin a day. You know, there's a very tiny risk of developing certain cancers or something like that. And it scares a lot of patients that really could benefit from these kind of medications. You know, still the overall number one thing that kills people in America is heart disease, heart attacks, strokes, things like that. And so patients that actually have peripheral arterial disease, they have blockages in their, you know, their vessels to their heart, to their carotid arteries, things like that, had strokes in the past. These medications really lower the chance of developing another event. So just like this, 20 to 30% risk reduction of non-fatal MIs, heart attacks, non-fatal strokes, or vascular death. The recommendations, 75 to 325 milligrams daily. That's kind of a mixture between European and American guidelines. Really, in America, our baby aspirin's at 81 milligram a day. And that alone, just a baby aspirin once a day, if you're diagnosed with PAD, it's really recommended to be on one of those. Or in some circumstances, Plavix, which is clopidogrel. And even in patients that have no symptoms, we're already starting to say, let's say you got a random x-ray for something, you see all this calcified plaque in there, you're like, doc, I have no symptoms. What does this mean? Even patients that don't have symptoms, it's still recommended to take a baby aspirin. Because if you have plaque showing there, you may have the plaque in your heart or in your brain. And so really to lower the risk of a stroke and heart attack is the key things. Statins. This is another medication that many times gets a bad rap, and a lot of people don't tolerate them, to be honest. There's a big side effect profile. But for those that can tolerate them, and many times you have to try one and then go to another, they have a lot of other potential benefits than just lowering people's cholesterol. So if you have, significant peripheral arterial disease and you're facing limb threat and things like that, agents that will stabilize the plaque and lower the inflammation in your bloodstream and things like that, which are some other effects these statin medications have, then they're really helping out even if you have, let's say, normal cholesterol levels. And so your doctor will probably recommend trying a statin in addition to the aspirin. Those two medicines are really the main medications that I kind of offer to all my patients. Treating people's blood pressure, and there's lots and lots of different types of blood pressure medications, and it all kind of depends on heart rate and several different factors. You have kidney disease and whatnot, diabetes. But we do know that you're 2 to 4 times more likely to develop claudication, which is that pain in the calves when walking, in patients that have high blood pressure compared to those that don't. Diabetes. Diabetes is the number one reason that leads to people getting amputations. And the really difficult thing with it is not only the infections that people can develop in their feet and whatnot, it's kind of this triad. You have the infection, you have poor nerve endings, and if you get plaque buildup, and it usually affects the tiniest of blood vessels that we really don't have great technology and treatment options for, that's it. Like if we try to take a toe here or something there and we kind of hope it heals and stuff like that, we try to myodify everything we can. But really the thing and overall goal that we want to try to do is try to prevent that from getting to that stage. So things like getting a good podiatrist, doing good preventative foot care, making sure you have well-fitted shoes that's not causing pressure points, all of that's very important. So patients with no symptoms. If you have technically an ABI of less than 0.9, which is that blood pressure study, but you have no symptoms whatsoever, you're still at increased risk for heart attack and stroke and dying from those. So it's recommended to start on those medical therapies, even if you're not having any symptoms. So some people that are like, oh, your primary care, maybe they're doing a good, thorough physical exam on you. Notice, it's kind of hard to feel your pulse here. Do you get any issues in your legs when you're walking, anything like that? And they say no. Maybe I'll order a screening ABI, and yep, it was 0.7. And say, okay, well, doc, what should we do about that? Well, we should really kind of consider these medications, not just for your legs, but for your heart and brain. So when we start to move into claudication, the good news is there's a less than 5% annual risk of moving into that critical limb ischemia stage, those gangrene, the constant foot pain, things like that. Most people will stay about the same year to year. Now, there will be tendencies to a general decline just as we age, unfortunately. The other good news is there's about a 1% chance of amputation. So very, very likely that someone will get an amputation in the next 5 years if they're in that claudication stage. Other medications that can be considered for this is another medicine called Slostazol. So if you have a blockage in the major, let's say like Interstate 10 shutdown, and we got to get flow through there, well, it's going to take the side streets to get around, right? The frontage roads. So similarly, our body will create collateral vessels around these blockages, and Slostazol is kind of a medication that will help encourage that collateral flow and try to dilate those vessels up. Thing is, it takes a lot of times several months before you'll notice effect. So it's one of those situations where you're like, well, doc, we live in America. I can go get instant gratification in so many things. Where a good, wise vascular surgeon will say, in your really best interest, we should try these things before we start doing interventions. The other thing is an exercise program. So just walking 30 to 45 minutes a day, at least 3 days per week. This is kind of like an athlete training their body. We're trying to encourage that flow around those blockages. And most people, if they stick to these two types of therapies, will double the distance they're walking before they get this pain in 6 months. So good news with claudication, it's very, very less likely to go to a critical stage, very, very unlikely to result in amputation, and people can tend to get better with time too if you start to work on all of these different things. Now, if we get to the stage, sometimes people present a little bit later and it goes, doc, I can't walk to my bathroom before the pain gets in. I can't go from my bedroom to my kitchen without having to stop. I can't go from anything practically. I haven't been able to hold a job for 6 months because I can't walk around and do these things that my employer requires. So these are very lifestyle limiting claudication symptoms. In those circumstances, then an intervention, whether it be an open surgery or things like a stent, may be necessary or may be recommended, just depending on how much it's affecting your lifestyle. And once again, a conversation with your surgeon. So now into the critical limb ischemia or chronic limb threatening ischemia. In these circumstances, yes, we need to improve the flow and we need to do it sooner than later. When people are in rest pain or tissue loss, because you're much more likely to develop limb loss in these stages. So especially in rest pain, once again, this can be kind of confusing, and I get a lot of people sent to me for foot pain, and they're kind of wondering, okay, is this related to arterial disease or is this something else? So things like gout or arthritis, or a lot of times diabetic neuropathy or neuropathy for other potential reasons. A lot of these things will mimic quote unquote like rest pain. And so once again, listening to the patient, what are their risk factors, examining their feet, ordering studies, these will help differentiate between them. When patients are in this kind of stage, not only are they developing all these blockages in their legs, like I talked about, within their heart and their brain, they have a lot of issues going on usually. And so the 5-year risk of them dying is 30 to 90%. It's pretty high. It's almost like a cancer diagnosis. And so it's a conversation to be had. It's about expected outcomes and goals, and what are we trying to do, and making sure that we're not only just focusing on the legs, but we want to focus on your entire health. And so making sure, hey, do you have a cardiologist? We got to make sure you're getting checked out for these things. We don't want to neglect the overall situation of what's going on. And so when patients have rest pain, we really want to improve enough flow to kind of raise the pressure enough to just get them out of those symptoms. Now, when somebody has a foot wound and the wound's not healing because you can't get oxygen and nutrients to it, we really got to get as much flow directly to the wound, because it takes a lot more energy to heal a wound than just to maintain tissue. And so a lot of times that requires a lot more extensive operations than something like the rest pain. And there's another entity that we'll just briefly touch here. It's called acute limb ischemia. This is like all of a sudden, I have horrible pain in my foot. It turns white. It's become cold. I can't feel it. I can't move it. Those kind of things. That's like an immediate emergency. I need to go to the emergency room. This is like suddenly you lost all blood flow, or a huge percentage of your blood flow to your leg or arm. And if you don't restore the blood flow, then that can rapidly progress to losing the limb. So now when we talk about surgical therapy, kind of one of the mainstays and early things as technologies are getting better is endovascular surgery. It's nice. It's minimally invasive. It usually requires just a poke in one of the groins or the foot. And as you can see in the picture in the middle, there's a blockage there. So the black column is the flow. That's the contrast you inject through the blood vessel. And it almost goes down to probably like a 90% blockage there, or just a little string of blood flow getting through there. And hopefully this video will work. This is now eventually popping that blockage open with a balloon. So a lot of times we'll start with a balloon, re-image it, see what it looks like. Is it flowing normal now? It's still a lot of significant blockage. The balloon didn't quite do a good enough job. And there's other things that can be done, like a stent or an atherectomy that people talk about, like a roto-rooter, and kind of core it out. Other treatment options are things like open surgery. So we're essentially just fancy plumbers on blood vessels in the human. So you can physically open up the pipe, scoop out the blockage, and then sew it back together, or you can sew a bypass around it. Those are kind of the main different ways of open surgically treating these blockages. And sometimes when we do the bypass, we talk about harvesting your own vein, just like the chest surgeons do, the heart surgeons do in the heart. Take a vein out of your leg and turn it into a new artery. Or sometimes if there's no vein available, which we prefer to use a vein because it has the best outcomes, then sometimes we'll use sort of like a plastic tubing or what we call a graft. Or sometimes even cadaver veins. So just a few more examples of cases here. So on the far left, you can see there's a complete blockage, and you see the little collateral vessels getting around that kind of major highway vessel. And then after you treat it, you can see how the flow is just going straight down, and it's barely going through any of those collaterals now. So it's preferentially going down the main artery. And on the more right side of the screen, this is what is more affected in diabetes. So the ones on the left, that's up in the mid-thigh area, and the ones on the right are below the knee. These vessels get smaller and smaller. And so as you get smaller and smaller vessels, they get harder to physically treat. And also any ballooning or stenting you do, when you talk about like a 2 millimeter blood vessel and you just barely pop that open, it doesn't take a whole lot of rebuilding a plaque to completely shut them down. And so when you have a much bigger blood vessel, you start up in the aorta, up in your abdomen, and you start to branch down, those vessels will tend to last much longer and have good long-term results. And this is why it becomes really difficult in diabetes, because it affects these really small ones. And as you get in the feet themselves are even smaller, that we don't even have capabilities to do a lot of this stuff. This was a gentleman that initially I was able to get one of those vessels open. You can see picture 1 to picture 2. Now there's that big long vessel that's getting down there. And then it shut down, unfortunately, pretty quick. Like I talked about, those vessels are really small. Like a month later, that shut down, unfortunately, for this gentleman. So we decided with him and had a conversation, and we decided to do a bypass. And so you can actually see the picture of the bypass in that third picture. It's kind of going off towards the screen right, going around the blockage, and then you can see sewed into that much smaller blood vessel just above the ankle. These are kind of examples of what these technologies look like. There's all sorts of different types of balloons, and we call cutting balloons that have ways to kind of open up these blockages. The picture down to the bottom right, even though it looks like electricity just like exploding inside of somebody's vein, but really it's more of what we call these like lithotripsy balloons. Essentially, just like they break up kidney stones, we're using different technologies to try to fracture calcified plaque and trying to open up these blood vessels. And then there's all sorts of different types of stents, which just depends on the anatomical location, and should we use this type of stent versus that type of stent. We use stents that have like a raincoat kind of material like you see on the right side versus ones that don't. And so that just kind of, as a vascular surgeon, we just have lots of tools and things to work with here. The other thing is we have these fancy ultrasounds where you can see 3D images actually on the inside of the blood vessels. So you can kind of see the plaque, the kind of the black circle around there, that's kind of the edge of the vessel, and this crescent white is the plaque that's building up inside of the blood vessel. And so when you take a two-dimensional picture like all those x-rays we were showing before, well, if you have kind of a flattened shaped blockage, just however the body decided to form the plaque, well, in one view, it may look like, oh, it looks pretty wide open. But then if you turn it from a different view, you can say, oh, wow, actually it's 70% blocked or something like that. Where these technologies where we can use the ultrasound within the blood vessel themselves, we get very clear pictures, and it really helps in pinpointing and actually accurately treating these lesions. There's other types of balloons and stents that are now administering medication, because one of the big things that we battle with is whenever you're doing these interventions to the blood vessels say, I just got injured. Essentially, you're causing an injury to the blood vessel wall. And so that response is, all right, now I want to form scar tissue on the inside. And so how can we help slow or diminish the amount of blood vessel scarring that occurs on the inside of the vessel? And so a lot of these new medications that are coated on some of these balloons and stents will actually help preserve and get a longer lasting outcome. And we talked about different like rotor-rooter techniques. There's lasers that can do it to help clean out and physically debulk some of the plaque. One of the issues is as you're breaking things up, there's always a chance that something can break loose. And so we have these nets that can be put down the vessel a little bit further. So if a piece of plaque does break loose, it doesn't get stuck further down where it's really hard to get out. And so these little nets can be available to kind of catch things if we're really concerned that may happen. And some kind of future things that actually some of these things are already here in place is like the stent on the left side are these bioabsorbable. So, foreign bodies inside our bodies are always constantly forming reactions to foreign bodies. And so now we're developing these stents that over time our body will just absorb them. So we'll get more of a longer lasting, we call like a remodeling of the blood vessel, but we're not leaving a permanent piece of metal in there that will continuously have a body's inflammatory response to it. Other things that people are looking at and researching is, we have different ways to screen, but everybody has a cell phone. And so if podiatrists or vascular surgeons can use different types of technologies where we just walk in and take a picture of your foot and say, yep, this part of the foot where your wound is has very little blood flow. And so using things like thermal technologies and things like that may be down the line to kind of help pinpoint and treat and accurately kind of diagnose who's going to really benefit by an intervention or not. One other thing I always like to talk about is, vascular surgeons, cardiologists, a lot of people that treat these things, interventional radiologists. There's been in the last few years a lot of news about people sort of abusing these procedures. For a lot of people, they can be extremely lucrative and they can be very financially compensated, especially if they own their own surgical suites and facility. And so there's a challenge sometimes where people will tell people, hey, we're going to prevent amputations by doing all these interventions on you. And you're like, doc, I'm having no symptoms. Are we sure we should do this? Oh, you got lots of plaque. We should do this. And so there's been, unfortunately, just like in a lot of industries, bad cops, bad lawyers, bad whatever, there's, physicians that sometimes, will take advantage of patients, unfortunately. And fortunately, a lot of these are getting cracked down on. And, the patients that really need these things and really benefit and it makes sense for them, we want to make sure that they keep getting the care that they do and that physicians and otherwise aren't abusing those relationships. And once again, the key thing with all this, and I hope for everybody here in the audience and online and everything, we want to really move to where we're preventing these things. It breaks my heart when seeing people get amputations and how much it affects them. And moving into almost that end of life stage. We talked about people in those late stages, 30 to 90% mortality in 5 years. It's pretty significant. And so doing things like modifying your blood pressure, your diet, getting active. I always tell people, stay active. When you retire, don't just become sedentary. That's going to be the worst thing for you. Go do stuff, get out, enjoy the nature. We live in beautiful Tucson. Go enjoy it. So that's the presentation I have. I appreciate you guys' time. I'm happy to take any questions. Thank you.
So thanks so much, Dr. Kraemer. So I do have some questions that came in, and I think this is something that we don't talk about as often, PAD in general. And one of the things is are there early signs that maybe you don't realize that could indicate PAD? Is there something that we should be maybe watching more closely that happens at home, or?
Yeah, I think it's the probably the first symptoms that people experience is that kind of claudication pain, the calf pain when they go out and walk. And, it's hard to differentiate, hey, is this just because I overdid it today? Or did I pull a muscle? Because all these other musculoskeletal joint issues, far, 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 far more common. But if you're real honest with yourself, I'm a long-term smoker. I smoked for 40 years. I'm starting to notice things. I think it's best to, let's just get this checked out. Let's just make sure we're not in a situation where we got something serious going on. And it's not just your legs health, it's your heart, your brain. So it's very important to, if you're concerned, a simple screening, that blood pressure study test, doesn't take a lot of time. That would be a good quick way to kind of get a little reassurance or some guidance.
And how much do you see obviously the correlation between PAD and stroke or heart attacks? I mean, I know obviously there is correlation, but how high is that? Is it a big risk or?
Probably there's more likelihood to just have the coronary stuff going. That's probably more likely than people developing peripheral artery disease. But like what we talked about over on the smoking risk factors, actually people will develop more symptoms related to that rather than they will just of the heart disease itself. So it's kind of a mixture of the two, where I think the heart disease is probably overall more prevalent.
Okay. And are there any certain medications that increase your risk of developing PAD at all?
Probably nicotine.
Okay. Okay. Okay.
Yeah.
And is there a reason you wouldn't use a balloon or a stent treatment? For instance, is there an age that might increase your risk of damage to the blood vessels?
Not necessarily. There's as we get older, and let's say we're contemplating between, should we do an open bypass surgery, which is going to be multiple incisions up and down the leg and a 4 to 6 hour operation under a general anesthetic, versus maybe a stenting procedure, which may be an hour and a half to 2 hours, and we just do a little mild sedative and some numbing medicine. In all honesty, the bypass is kind of the Cadillac operation. It's going to last longer. It's going to be a more durable fix. But if we have somebody who's more frail, they have a lot of other medical conditions, and they're going to be increased risk for a big operation like that, then we may decide, really probably the stenting or ballooning procedure is probably the best way for this individual.
Okay. And is obviously the recovery time must be shorter on that one as well, I would assume.
Yeah.
Okay. Okay. If somebody is interested in getting more information, I do want to go ahead and put up your phone number. Obviously you're operating out of TMC and Rincon. Is that correct as well, or just
not so much out of Rincon. A
Okay.
lot of these operations and procedures require kind of the main hospital's resources. So.
Okay, so we have your clinic though. The phone number is 520-420. 2450. If they are interested, can you just tell us where that office is located?
Yes, it's actually located very close to Northwest Hospital. It's on La Cholla.
Okay, it's on La Cholla. Okay, great. All right, so if anyone is interested, please feel free to give a call over to that clinic for an appointment. I want to thank you so much for being here, Dr. Kraemer. I'm going to wrap up with our online audience, and I will turn it over to you for any questions in person. Thanks for being here today.
Thank you so much.
Thanks. Thanks again for joining us. We look forward to seeing you again next week. Next week, we have Mindful Aging, Mental Health and Mental Wellness for Older Adults. That is on Wednesday, April 9th at 10 a.m. If you're interested in that class, please give us a call. The phone number is 520-324-1960. Also next week, we've got on Thursday, April 10th, Understanding the Power of Palliative Care. That is Thursday, April 10th at 10 a.m. with Dr. Shana Simmons. And again, please feel free to give us a call in the office, 520-324-1960. That wraps us up for this week. We hope that we get to see you on Saturday for Stroke Prevention Saturday. If you are interested in that, you may also give us a call. And we'd be happy to get you set up for appointment time to get started. The phone number again, 520-324-1960. Have a great day.